Thank you all. I have about 7 or 8 questions, so I'll ask you to be succinct in your answers, and if I interrupt, it's not to be rude, just to get to them. CDC, we discussed beforehand, I've discovered that the Canadians have not been as strict in terms of people returning from Hubei province. If you're febrile, they quarantine you. If you've just been there and you're not febrile, God bless you, go home and don't infect anybody. Now, you had mentioned that there is screening at the U.S.-Canadian border. What % of those folks coming from Canada in, say, Washington State are actually being screened, either by a questionnaire as to travel history, exposure, and or temperature, et cetera?
Yeah, I don't have the %, but we've worked closely with Dr. Cadlick's team and the U.S. Public Health Service, as well as the CBP.
But can you give me a ballpark? Is it 10%, 50%?
There's a protocol that is assessing everybody who's crossing at the key borders to alerted to where the flights are coming in and so forth, but we don't. I can't give you a percentage. Sorry.
But it could be as low as 5%.
It could be.
Yeah. Mm-hmm. Secondly, is CDC using Google location data or something similar in terms of tracking contacts?
Not for contacts. We are for travel patterns and for other means. So
going to this nursing home in Seattle, clearly somebody came who had been exposed to the coronavirus. Law enforcement at a scene of a crime will get a warrant, will ask Google to give this data. We've been reviewing the statutes. So just to be clear, CDC is not currently using that same sort of thing law enforcement is to track contacts?
You have to recognize that right now the chances that a person with a fever and cough have coronavirus versus influenza are very low. So exactly what we'd be tracking, I'm not sure.
If somebody went to that nursing home and you can follow their location data, and it turns out they had contact with somebody who had traveled to Hubei, perhaps in Canada, they had gone back and forth, then they're obviously a candidate for being the vector. So I would encourage, because I think the answer is no, that you do use that location data. It seems as if that would expedite the epidemiology of how this is being spread among the community. Next. Dr. Han, those 26 APIs that India is not allowing to be exported, are any of those the active pharmaceutical ingredient for any of the candidate therapeutic drugs?
Senator, I don't know the answer to that question. We're going through that list right now to actually assess the effect on essential medications.
Okay. Next, one of the recommendations that Senator Murphy and I had in a request in a drug shortage report from FDA, which was released last year, recommendation number 2, was to establish a quality supply chain rating system. Now, should Congress enact this quickly? Because clearly, if we've got supply chains overseas that we can't inspect and/or they are basically interdicting the flow of that active pharmaceutical ingredient to the U.S., and it could be one of these candidate drugs, again, should we now enact that recommendation number 2?
Senator, we stand behind and are working on the development of this rating, rating system. We'd also have some legislative proposals as part of the President's budget that relate to this.
Okay. Next, as regards the, we have a problem with antibiotics, in which if you had a very expensive antibiotic for some terribly resistant drug, it's difficult for us to currently pay for them with capitated payments to MA plans, for example, or DRGs to hospitals. We could have the same situation with antivirals, whereby the antiviral might be very expensive, and that would kind of blow the lid off of a DRG or you see where I'm going with this. And so, again, I would like Congress to act upon this quickly to create some sort of carve-out for these essential but expensive drugs to develop. Your thoughts?
So we have implemented the authorities given to us in the GAIN Act and also in the Cures Act to help with this, and we are very much facilitating the development of antibiotics.
But I think this would be a payment policy on the part of CMS. I think we'd have to give them the authority to do an epi-payment, if you will, for the use of such drugs.
I know that we have a pilot project with CMS to bridge this gap to the payment side. I defer the payment questions to CMS, sir.
Dr. Fauci, we're looking for quick diagnostics. Obviously, a PCR takes a little bit longer than a swab or a blood test for an IgM or an IgG. How close are we to having an IgG or an IgM blood test that could be quickly turned around in a community hospital?
Yeah. I think pretty close, because that's clearly one of the things we want to get. And in fact, it'll be very important broadest surveillance in the country of exposed people who never come to medical care.
I want to finish up by saying this. We need to know from y'all what authorities we need. As I look at this, we need expanded telehealth with expanded use authority. We need to give appropriate reimbursement for that telehealth. Granted, that's all CMS. But we also need home health. Ms. Murray was saying how we got to send people home. I think we need to do something there, and I think these are those my questions. If you need authority from us, please let us know. It may be the expanded authority Senator Burr already referred to, but we need to know what else you need. I yield back. Thank you.